In this lecture, we're going to talk about how various types of clinical research have been useful in developing evidence-based practices in addiction treatment. And we're going to use screening, brief intervention, and referral to treatment as an example. In subsequent weeks, we will focus on psychotherapy research and pharmacotherapy research. But let's start with a good example of the different types of clinical research that are relevant to the development of evidence-based practices. Let's start with the definition of clinical research. Clinical research consists of a broad range of research tools, not just randomized clinical trials. It's designed to improve the effectiveness of interventions for people with alcohol and drug problems. It includes not only clinical trials, but a variety of ways of developing the rationale for clinical trials, preclinical research, which can include the development of measures and methods and research designs, psychometric analyses of ways of identifying patients who might be eligible for a particular intervention. All of these things are part of clinical research. In addition to randomized clinical trials, after those trials are done, clinical research provides ways of evaluating effectiveness in settings that aren't as artificial as those created in order to establish efficacy in a randomized clinical trial. So we go from the laboratory into the regular clinical environment to see what was demonstrated in the laboratory will prove itself to be effective in the real world. And if we gain that evidence, we then need to figure out how to translate those findings into the healthcare system. So that's another stage of clinical research. In this lecture, we're going to provide examples of how this full range of clinical research tools were used to develop SBIRT, otherwise known as screening, brief intervention, and referral to treatment. Although we've provided some examples of this kind of research in prior lectures, here our purpose is to show how clinical research has brought SBIRT to the point of worldwide dissemination. So let's review the different types of clinical research that are available in the toolkit of a clinical researcher. First, preclinical studies. And we mentioned these are sometimes pilot studies to identify safety and potential efficacy, but they can also include psychometric studies that allow us to put together the framework for an intervention. In this case, we're talking about brief intervention research, which would not be possible unless we had a mechanism for identifying people at an early stage in the development of their alcohol or drug problems. Beyond preclinical studies, the centerpiece of clinical research is certainly efficacy studies, usually based on randomized clinical trials. And these RCTs are designed to evaluate treatment efficacy under controlled experimental conditions, where we rule out all other sources of influence except the intervention to demonstrate the potential causal mechanism that might be involved, in this case, the intervention itself. Once we've demonstrated efficacy in a controlled environment, effectiveness research is needed to determine whether these efficacious interventions demonstrated in RCTs are actually capable of producing equivalent changes in the real world. And here we can use randomized trials or observational analytic studies that test out an intervention in usual care settings with a much broader patient mix. Those are effectiveness studies. If we can demonstrate effectiveness in the real world, the next step is translational research. Using these basic findings, we then engage in one of two types of translational research. One is going from the bench to the bedside, and that usually means going from efficacy to effectiveness research. And sometimes that's sufficient, but often we really want to know more, not just that our intervention is effective, but that it can be implemented, that it's feasible. And this is called T2 translational research. It's designed to demonstrate a bedside intervention into the healthcare system itself. And this is also called implementation and dissemination research. So let's take SBIRT as an example. SBIRT means screening to test whether we can identify people in the development of their substance use disorder, usually prior to the development of dependence. And we know that many people, once they get started smoking tobacco or using alcohol or illicit drugs, are not necessarily addicted. And if we could identify them at an early stage in the development of their use, we might be able to prevent, through an intervention, the further development of dependence. The mechanism for intervening is usually called a brief intervention. This means time-limited counseling to reduce further risk, often with the strong recommendation that people cut down on their use rather than stop entirely, particularly with legal drugs like alcohol or tobacco. Brief interventions are also characterized by their low costs, their ease of use, and the fact that they can be delivered by a variety of different health professionals. Another part of SBIRT which has come into play is what to do with people who are screened and identified as being alcohol or drug or tobacco dependent. A mechanism is needed to get these people to seek treatment. And SBIRT can be used in terms of brief intervention techniques to motivate people to seek referral if they've developed a dependence syndrome. Here we have a distinction between the classic target of most treatment research, which is the down-and-out skid row alcoholic or the street drug addict. These people are not that difficult to identify in clinical settings, and if we can identify them, we can refer them to treatment. But what SBIRT has done is to broaden the base of treatment and intervention and try to identify people who are at various stages or levels of risk, starting with social drinkers and recreational drug users, moving into hazardous and harmful users, people who have begun to develop problems, but who may not be dependent. And SBIRT is relevant to the full continuum of hazardous and harmful substance users, as well as those dependent. But in particular, the focus has been towards the early identification and prevention side. A brief summary of the literature that has led to the development of SBIRT programs is relevant here because it provides a great illustration of the use of clinical research in the development of evidence-based practices in addiction treatment. During the 1970s, there began to be interest in biological screening tests, usually liver enzyme and liver function tests, to identify people with alcohol problems and to provide a verification of a diagnosis of alcoholism or alcohol dependence. Out of these came self-report screening tests, which were often found to be just as sensitive and specific as the biological screening tests. But still, they were designed to focus mainly on people with alcohol dependence. What changed in the 1980s was a call from the World Health Organization to try to integrate the identification and management of substance use disorders, starting with alcohol use disorders, in primary care settings, realizing that in most parts of the world, there was no specialist treatment system for people with alcohol or drug dependence. And if we were going to have appropriate interventions, we needed to do them in most parts of the world within the primary care setting. Doctors seeing patients for a variety of conditions who are not specially trained to treat alcohol or drug dependence. So WHO began to develop screening methods and intervention methods that could be used in primary care settings. And they developed the concepts of hazardous and harmful drinking, which you should be familiar with, and began to do clinical research on screening tests and brief intervention techniques. Out of this came the development of the alcohol use disorders identification tests and the ASSIST screening test, which you will read about in your assignments for this week. And there have been many other second-generation screening tests that have been directed at different at-risk populations. Pregnant women, adolescents, the elderly. There are now 30 or 40 different types of screening tests which can be used to identify people at different stages of development of an alcohol or drug use disorder. Following the development of these screening tests, there were a variety of clinical trials, which both small-scale and large-scale trials demonstrated that under optimal conditions, one can produce greater changes in a group exposed to an intervention, people usually not alcohol or drug dependent, than people not exposed to that intervention. After the year 2000, more randomized clinical trials and effectiveness studies were conducted, and we began to see systematic reviews of the literature and meta-analyses demonstrating in study after study that there is a positive benefit from screening and brief intervention. This was followed in the last 7 or 8 years with national demonstration programs in the U.S. and other countries, the development of new intervention technologies, new biomarkers, and now translational research on implementation and dissemination. The cutting back study has already been described in earlier lectures from a clinical research perspective. But here I want to share with you more of the results because it's a good example of going from the preclinical studies of developing psychometrically sound screening tests to the clinical intervention studies using randomized clinical trials to effectiveness research combined with translational research. Cutting back asked the following questions. Can evidence-based practices like alcohol screening and brief intervention be implemented in real-world primary care settings, in managed care organization environments? These are primary care clinics that are run by private organizations that have contracts usually with employers to handle the healthcare needs of working people. And they're excellent ways of studying the innovations that might come out of clinical trials. Another question that Cutting Back asked was which provider training models, either a doctor taking full responsibility for the intervention or having a nurse practitioner or a health educator dedicating themselves to finding patients, screening them, and when they're identified, following up with an intervention. That was a second model. we also wanted to know which provider training models produced the greatest change, but also which provider models were the ones that were easiest to implement. Another question that Cutting Back asked was, does SBI reduce at-risk drinking? That's the obvious question of an effectiveness study. And in terms of implementation, Cutting Back wanted to know what factors were associated with successful implementation. The research design was randomizing clinics. Each MCO, each managed care organization, provided access to 3 of their clinics. And one of them was chosen for a control condition where patients were screened and followed up at 3 and 12 months, but they received no intervention. A second set of clinics where the doctor served as the SBI provider. Sometimes he had somebody else doing the screening, but the doctor was responsible for delivering the intervention. And then patients were followed up by a separate follow-up team by telephone. And a third group was a specialist model where a nurse or a health educator was trained to do both the screening and the intervention, to coordinate them. And these were done in an equal number of clinics. Follow-ups were conducted at 3 months and 12 months after the index episode where they were screened and received an intervention. And here you can see the results for the control group and for the doctor-provider group and for the specialist provider group. And you can hardly see any difference between the specialist and the doctor, but both of them did better in terms of reduction in drinks per week at the 3-month and 12-month follow-ups. The reductions are not dramatic, but in large numbers of patients, they're clinically meaningful and significant. So what this demonstrated was that regardless of whether a doctor delivers the intervention or somebody like a nurse or a health educator who's trained especially to go out and screen and do the interventions, you get a similar reduction. And that is a reduction that occurs over and above what happens when people just fluctuate in their drinking over time. Another finding from the Cutting Back study was that at-risk drinkers who received the intervention after the screening differed between the doctor-provider model and the nurse health educator specialist model. What happens in many attempts to implement evidence-based practice is that people get lost in the shuffle. If somebody's screened, the results don't get to the health professional on time for them to catch the patient before the visit is over to deliver the intervention. And that occurred quite often, 43% of the time, for the doctor providers. So only 57% of the patients who screened positive actually got an intervention after the screening was done. Whereas when you had a specialist or a health educator doing this, 76% of the patients got an intervention. So training people to deliver the intervention results in a higher implementation rate at a lower cost. Finally, Cutting Back looked at this study of 10 clinics where we implemented a screening and brief intervention program in terms of the characteristics of the clinic that were most responsible for high rates of screening. And those clinics who had the following predisposing factors had much higher rates of screening as well as brief interventions. They were clinics which had stable patient membership and organizational stability. Think of the example of one clinic where there was frequent changes in clinic management. Clinic management were not happy about hosting a new program on screening and brief intervention, and they did not communicate well with their providers. In that clinic, the number of screenings was very low, and the morale was low in the doctors and the nurses to the extent that even if screening was conducted, they weren't very good at delivering the brief intervention. So stable patient membership and stable organizations make for higher rates of implementation. Similarly, there were a number of enabling factors that helped to implement the program in these clinics. If providers had more time and didn't complain about the lack of time, they were more able to deliver the interventions. If there were fewer organizational priorities, like competition for screening for diabetes and other health conditions, they were more likely to adopt screening and brief intervention. And if there was a champion in the clinic, somebody who was really interested in alcohol to the extent that they really were committed to getting this program implemented, then it was more likely to succeed. Staff involvement in planning is important, and the existence of technical assistance and clinical research asking people what made for a successful program was able to provide enough data for us to look at correlations between these enabling factors and the frequency of screening and brief intervention. And finally, organizational support. You need to have top-down leadership support, and you need to have bottom-up support as well. So that's a good example of how SBIRT implementation research followed from effectiveness in clinical trials and how it demonstrated effectiveness in real-world clinical settings. And not only that, how it told us a lot about the conditions under which you can successfully implement an SBIRT program. Following that and other research, we've had worldwide growth in screening, brief intervention, and referral to treatment. Based on the reviews and the implementation research, we've got national level programs in Finland and Brazil, the USA, Sweden, and other countries. And in Connecticut, we have a program funded by the federal government. It's one of 27 states which has a national demonstration program. And we've screened here in Connecticut over 65,000 patients under this program in a variety of different federally qualified health centers. So in summary, over the course of 35 years, clinical research took SBIRT from an abstract concept of early intervention for hazardous and harmful drinking into national implementation programs in the U.S. and in other countries. And the clinical research itself was necessary at all levels, not just the randomized clinical trials to demonstrate efficacy, but the work on psychometric evaluation of screening tests that came before it, and the pilot studies of brief intervention techniques using behavioral and motivational techniques, and following the clinical trials, the effectiveness in translational research.